Hello, it's Dr. Shelley with Shelley's Nursing Review and HETV, Health Education Television. And this behind me is what I have promised you for a few days now. It is congestive heart failure medications. Now, a lot has changed. So when you look at how to treat a condition like congestive heart failure, you have to kind of review pathophysiology and understand that the way we treat a disease process is to understand what actually causes the disease process and to direct those medications at that issue. So there's several issues with congestive heart failure, right? One thing we know about it is there is no cure. So these medications are really to almost suppress or slow down the progression of the disease because there is no cure. So there's not like we're gonna, slap these medications into the mix and all of a sudden our beautiful patients are gonna be cured. Not gonna happen, okay? So there's no cure. Congestive heart failure is quite progressive, and there is, from the day of diagnosis, we know that 50% of the patients from the day they're told that they have heart failure, no matter what severity it is, the day they're told that they have heart failure, 50% of those patients will die within that 5-year time frame, which is tragic. So our job is to try to delay that date of death and to maximize the quality of life the whole time that these patients are with us. Now, when we look at these medications, CHF medications and management, we want to remember that all congestive heart failures are not created equal. Now, remember in the last video, we compared and contrasted left side with right side, diastolic, systolic, okay? Quick reminder, if it's on the right side, heart failure, cor pulmonale, it was a lung disease that caused it. If it's on the left side of the heart, then the fluid is backing up into the lungs. And of course, it was a pre-existing cardiac disease that caused it. Number 1 cause is hypertension. Number 2, previous MI. Just a quick review. But there are literally classifications or stages of heart failure. And I do think that you really need to understand them fully before we jump into meds. And it's really easy. It's not hard. So there's 4 classifications, and sometimes people say stage 1, stage 2, stage 3, stage 4, or stage A, B, C, or D. It doesn't matter. You say tomato, I say tomato, blah, blah, blah. But let's look at the first one, because stage A or class A, there are no signs and symptoms. And before I go too far, let me remind you, we are in the cardio packet. There's several handouts in here for heart failure. One says treating congestive heart failure, and then it splits it up into right and left. It's really a great handout. It is part of the comprehensive bundle that we sell. Also, you can get it by itself as well through PayHip, okay? So now that that's done, let's look and see what we got here. When we look at class A heart failure, we know that at this point, there are no signs and symptoms, and there haven't been any signs and symptoms. In fact, what do we say about this class? We say this is the class of congestive heart failure that is at risk. And so when we look at that patient, we know that they could have several reasons why they're at risk. It could be that they had a congenital heart defect when they were born. It could be genetics. Those two kind of overlap a lot. It could be that they've had pre-existing hypertension, and certainly we know uncontrolled hypertension or hypertension, high blood pressure, in which the patient kind of haphazardly takes their medications, because keep in mind these medications can be expensive to fill the prescriptions. And so patients who kind of dip and dab and just do a little something with the meds, they are at very high risk for congestive heart failure. Hypertension being number 1. Maybe they have diabetes already. Perhaps they've had a history of cardiovascular disease. Maybe they've even had some obstruction. Their history includes a cardiac cath, a stress test, a Muga scan, an echo. Like you see all this, right? So definitely, and you know I say this every video I can, definitely there's obesity. Let's just keep it all the way 100. There is obesity. Alcohol or chemotherapy are examples of toxicities to the heart. So cardiotoxic agents to the heart include alcohol and chemo. And people don't really think about chemo, but it can be quite toxic to the heart. So that might be part of what makes this patient at risk. The other issue is lupus. My God, lupus is just mean and hateful. I have a precious, precious baby in my class with lupus, and she needs a kidney transplant. We are all praying for her. But lupus is just a bitch. What can I say? It's awful. Okay, so keep that in mind here with this classification. Again, the patient doesn't have any signs and symptoms, okay? Now, moving on to stage or class B. Class B heart failure has no signs and symptoms. However, they have all these risk factors, or a great bit of them. Oh, and you know what? I can't believe I did this here. Please, 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 you guys, to the class A, please put OSA. OSA, add that to class A, is obstructive sleep apnea, okay? All right, now let's look at class B. They don't have any signs and symptoms either. They have everything that class A has, but then we need to add evidence, actual evidence from tests or procedures that shows, oh, this heart has some structural damage. So structural heart disease, either the BMP, B-type natriuretic peptide, remember that, B-type natriuretic peptide. B as in boy, N as in Nancy, P as in Paul, BNP. The BNP is elevated, very often greater than 100. Maybe they are chronically high in their troponin levels. I know you probably think of troponins as only being related to an MI, but I need you just to remember it's heart damage. Increased filling pressures, typically on an echo. So the patient's had an echo, and the echo is showing some changes. And then, of course, previous MI. When a patient has a myocardial infarction or a heart attack, that part of the heart is damaged for life unless we caught it early. But typically we don't, and it's a full-blown knockdown, drag-out heart attack, and this is what we see. Another classification of congestive heart failure for you to remember is class C. And this is where the patient is when you meet them typically. Most nurses are going to meet their patients with congestive heart failure in this column. In other words, they have had symptoms, the classics. Some of their symptoms include shortness of breath on exertion or even at rest. Some of their symptoms include this cough they can't get rid of. Some of their symptoms include peripheral edema. And of course, there's this tricky one, and I want you to make sure you write it. Paroxysmal nocturnal dyspnea. So they get up in the middle of the night, in the middle of their sleep, and they cannot breathe, honey. That is a classic, okay? So these are real heart failure signs and symptoms. Maybe this is their first hospitalization, but maybe they've had a few others. They have a current history of, they have current signs and symptoms, like I said, and then they've had a history of CHF signs and symptoms. So this is not their first rodeo. They've been down this street and up this parking lot before. They feel sick. They know something's not quite right, and it's really bad. Now let's take a look at all three. If you look in this area. We're trying to prevent the progression of this disease process. So we are encouraging our patients to take their hypertensive meds, whatever they may be, typically an ACE inhibitor. We are encouraging our diabetics to keep their hemoglobin A1C below 7. We are encouraging our patients to do whatever they can to lose weight. And I'm going to tell you something, because I've been telling you guys, these shots are amazing. We are encouraging these patients to look at options where perhaps they can get those weight loss shots. Stay tuned. I believe they're going to be covered in the next few months. I just believe it. I mean, it's just really unfair and terrible not to cover weight loss shots when they're so effective. So we're encouraging this patient who is obese to lose that weight, to get up and walk 3 times or more a week, preferably 5 times a week. So we are doing everything we can. We're trying to get this patient in treatment. Please stop drinking. You're going to kill your heart doing this nonsense, right? So this is what we're saying, okay? So, you know, we're getting this sleep apnea patient, obstructive sleep apnea patient. We're getting them a sleep study, which is a EEG. We're getting that patient whatever CPAP or BiPAP that they need, and encouraging them to use it, because they're going to feel better in the morning anyway if they do. So we are everywhere along the way trying to manage this condition and prevent the rapid progression with that 5-year life expectancy in the back of our minds, okay? Now, the end stage. Well, this is quite frankly where medications, CHF medications, are probably not going to do a whole lot. And this is where we start looking at heart transplants, LVADs, ICDs. We're looking at procedures or surgeries to help our patient at this point. They have had several recurrent hospitalizations. We call it the end stage. They most likely need oxygen more than they don't. So it's an end stage, sort of like end stage renal disease might be on the list for a kidney transplant. End stage liver disease, cirrhosis, might be on the list for a liver transplant. End stage CHF might be on the list for a heart transplant. So I just wanted to make sure that I clarified all of that. Now, what we know is when we look at this patient with all these meds, and they are on a lot of medications, the medications need to address the actual issue of compensation that the human body does in order to cope with CHF. Some of that compensatory mechanism or compensation that happens to keep you from perhaps dying from CHF can kind of hurt and help. It's kind of like, oh, I thought that we were, you know, getting on top of this or helping our body not die, when your compensatory mechanisms actually can make matters much worse. Let's remember the number one compensatory mechanism for CHF that we see. It would be called the RAS system. Renin, angiotensin, aldosterone syndrome, right? You got to remember this. I have lots of videos on the syndrome itself. I want you to make sure that if this is not going to be clear enough for you, you go back and look at some of those videos, because you can't get through nursing school or an NCLEX without knowing what the RAS system is. So let's try to summarize it in a quick way. Here's what happens. Your body has heart failure, which means the pump has broken. When the pump of your heart, which remember are ventricles, when they have broken, then you have a situation where your blood pressure more than likely is low. Now don't get confused. Yes, it may have been uncontrolled hypertension that caused the CHF. But once you have the congestive heart failure, it can be low blood pressure that we see quite often because your pump is broken. It's failing to get blood and oxygen to the body. It's failing to perfuse your organs. It's failing to fill up the chambers in the heart, and that's diastolic heart failure, or there's a failure of the pump to pump the blood out, and that is systolic heart failure. So no matter which one of those is going on, we know for sure the RAS system's going to kick in because that blood pressure is low and your kidneys are like, hey, hold up, what you doing? I ain't getting no perfusion up in here. I got some plans of my own to stop this nonsense because I don't know what the heart is doing, but it's on some bullshit. So I'm going to go ahead on and stop this now. So here's what happens. Renin is produced by the kidneys, and I'm going to say this slow because I need your behind to be writing this stuff down. So renin is produced by the kidneys. Think renin, think renal. And renin is a chemical that actually has a very mild, and I do mean super mild, like doesn't do anything, super mild vasoconstriction effect, very mild. So you don't even care to note that. You just know that's where we starting off at with renin. Now, renin stimulates the liver to produce angiotensin 1. I think you know a little something about that. If you look at the word itself, angiotensin, remember angiocath when you're putting in an IV, angiocatheter? Angio means blood vessel. But then that tensin, angiotensin, it sounds like tension. Putting tension on a vessel means you vasoconstricted that bad boy. So now angiotensin is a little bit stronger vasoconstriction. It's still not as strong as it's going to get because it becomes converted, and I hope you writing this down. It becomes converted into angiotensin 2. Angiotensin 2 is an extremely strong vasoconstrictor. So you're dealing with a patient who has this congestive heart failure. The body's trying to compensate because there is no blood pressure. When it tries to compensate, it's going ahead and it's making the kidneys help us out with the RAS syndrome. And when the RAS syndrome gets going, you got the renin, which was produced by the kidneys. Then you have your angiotensin 1, which is stimulated by the liver. And then, of course, you have your angiotensin 2, which angiotensin 1 is converted to angiotensin 2. Now, stop right here and make sure you write this. Remember that angiotensin 2 is going to get, it's super strong vasoconstriction, but it's going to start a whole cascade of crazy. And this angiotensin 1 is converted to angiotensin 2, where? In the lungs. So I needed you to write that. I stopped, slowed it down a little bit. I need you to write that angiotensin 1 is converted to angiotensin 2 in the lungs. Remember that, because remember when we start talking about ACE inhibitors and you inhibit the conversion of A1 to A2, the reason why you get a dry cough with them ACE inhibitors is because that must take place in the lungs. Okay, so again, renin by the kidneys, angiotensin by the liver, angiotensin converted to angiotensin 2 in the lungs. Wow. All right, now we now have angiotensin 2. And what you've got to remember is angiotensin 2 is going to stimulate ADH, anti-diuretic hormone in the posterior pituitary. It's going to stimulate ADH. Now think about that. ADH, anti-diuretic hormone. Why? Because the blood pressure was low. Well, when the blood pressure's low, it can't perfuse the kidneys. The kidneys then have to kick in and try to help themselves. When you can't perfuse kidneys, when the blood pressure or BP can't perfuse the kidneys, we say no BP, No PP, because you can't get PP if your kidneys are failing. Urine, PP, right? No blood pressure, no urine. No BP, no PP. It's what I've said for years. So now your kidneys are kicking in, trying to compensate and get the blood pressure to go up. Well, what causes blood pressure to go up? Vasoconstriction and volume of fluid. So here's the deal. We already got the angiotensin II. That's our vasoconstriction. So that's going to help the blood pressure try to, come up. But then I said that angiotensin II stimulates antidiuretic hormone in the brain or pituitary. Well, when that happens, antidiuretic, you really aren't going to pee. What are you going to do? You're going to retain fluid. What does retaining of fluid do to blood pressure? Makes it go up. What else happens with angiotensin II? It stimulates the adrenals, which are little scully caps on top of your kidneys. It stimulates the adrenals to put out aldosterone. Aldosterone. Sterone sounds like a steroid. Oh, you better believe it. Because when the adrenals put out aldosterone, that sterone, which sounds like steroids, does exactly the same thing. Oh yeah, steroids increase blood pressure. That would be a good plan here because your blood pressure sucked. And that's why the kidneys got involved with their compensation of RAS. So now we have aldosterone increasing the blood pressure, but how did it do it? Because this is what you got to know for NCLEX. It did it by retaining sodium. Now, if you retain sodium, wherever salt goes, water follows. Steroids make you retain sodium in water. So does aldosterone. It makes you retain sodium in water. And if you retain sodium, and this is why I need you to stay with me, if you retain sodium, remember sodium is the opposite of potassium. And so if sodium is staying up in the body, potassium would go down. That's what the RAS system is doing. But guess what? This video is on CHF meds. So then that means our medications that we choose to use must impact or stop or completely reverse RAS. All right, now we're somewhere. So look, the first category of medications is A. They're either ACE inhibitors or angiotensin receptor blockers, ARBs, or the newest medication that is actually more preferred called ARNI, and we'll talk about that in a minute. But let's get up on that ACE. ACE inhibitors. What does the word ACE stand for? Angiotensin converting enzyme inhibitor. So what did you do? This medication prevented the conversion of angiotensin 1 to angiotensin 2. Are you with me? I hope you're with me. I'm going to say that again. ACE inhibitors prevent the conversion of angiotensin 1 into angiotensin 2. Ooh. Now let's think about that. If the conversion of A1 to A2 is in the lungs, and the ACE inhibitor medication, lisinopril, pril drugs, if the ACE inhibitor medication stops conversion from 1 to 2, then you never get 2. And if you have to do this in the lungs to stop the conversion, you might get a dry cough. It's the #1 side effect. It's on a lot of tests. I hope I'm making myself very clear. So that's just the part about the A1 to A2. Let's tackle the part that you never got angiotensin 2. When the patient takes the ACE inhibitor, you never get angiotensin 1 to become angiotensin 2. So you no longer have 2. You've got this like week 1 out there, but that's it. And now you have to go back and remember, what did I say that angiotensin 2 used to do? Well, it stimulated the brain to put out that ADH. It stimulated the posterior pituitary to put out antidiuretic hormone. So you retain water. So if you take an ACE inhibitor, you're not going to get ADH because you never got angiotensin 2, so you're not going to retain water. Also, angiotensin 2 was stimulating those adrenals. Remember the scully caps on top of your kidneys, the adrenals, and they put out what? Aldosterone. So you don't have angiotensin 2. So guess what? You don't have aldosterone. And since you don't have aldosterone, you don't have sodium and water retention. So since you don't have any aldosterone, you don't have sodium retention. In fact, you're getting rid of sodium. You don't have water retention. In fact, you're getting rid of water. And if sodium is going down because you're getting rid of it, then the ACE inhibitor might make you retain potassium, because sodium and potassium are opposites. When one is down, the other's up sometimes, right? So no, you don't have aldosterone, so you're not retaining sodium and water. You're getting rid of sodium and water. You get rid of sodium, you get rid of water, but you kept the K. So why do I say that? Because number one, these drugs act on the RAS system. Therefore, they decrease the afterload and the preload. But you have to monitor the potassium and even the creatinine, because one thing we'll say about this, if the patient's kidneys aren't that great, well, they're going to hold on to potassium even more. So the risk of an ACE inhibitor or an ARB or an ARNI is potassium retention. Okay? All right? Does that make sense? And don't forget, the number one side effect is that damn cough. Okay? Now, we don't have angiotensin 2. Remember what else angiotensin 2 did? Angiotensin. Tension on the angio. What's an angio? A vessel. We don't have vasoconstriction. That was your afterload. Afterload is the vasoconstriction of blood vessels. We don't have any of that. So that's why we say the ACE inhibitor decreases your afterload. Afterload's a bad thing. A high afterload means a very high systemic resistance, right? You don't want that. Vasoconstriction is the same thing as systemic vascular resistance. I'm gonna get all up in your face and say that shit again. Vasoconstriction is the same thing as systemic vascular resistance. Systemic means the whole body. Vascular means all of your blood vessels. Resistance means they're shutting down or constricted. Okay, those terms used to fuck me up in school. I don't know about you, but they used to fuck me up. All right, so that's what we're doing. Now, peep this, y'all. If the ACE inhibitor gives you a cough, then we switch them to an ARB. Now, one more time. ACE inhibitors end in pril. ARBs end in sartan, S-A-R-T-A-N, sartan. That's what ARBs end in. So if you got a cough with an ACE on a pril, lisinopril, I'm going to switch your B hand to losartan or valsartan, an ARB, and I bet you'll do better. Okay, all right. Now, ARNI is brand new, and you got to know all about ARNI. ARNI's down here, we'll talk. Let's move on. The other issue is not only when you have congestive heart failure does the RAS system kick in, but get this. Your sympathetic nervous system kicks in as well, and this is very detrimental to heart failure patients, so that when we look at medicating to stop the sympathetic nervous system from kicking in, we've got to look at what is the effect of the sympathetic nervous system on the body. Now, I call this the fight or flight response. And if you know your fight or flight response, you may know that that has a lot to do with catecholamines or epinephrine and norepinephrine. So when we're looking at this patient who has this low blood pressure, the reason why we got all the way all up in the neuro system with the sympathetic nervous system is that when your blood pressure goes low, Your carotid artery and even your aorta has some sinus receptors on them called baroreceptors. Barometer, baroreceptors. These baroreceptors really pick up on the low blood pressure, and they go and they signal to the brain, the medulla. It signals to the brain, hey, we need some help here. This blood pressure is so low. We're going to need you to help us out with some fight and flight kind of hormones like epinephrine and norepinephrine. Now, side note, remember in the hospital, epinephrine brings dead people back to life by giving them a blood pressure and a pulse. Norepinephrine is synthetically called Levophed. Remember, Levophed leaves them dead? Well, norepinephrine is really Levophed in the pharmacy. But your body makes it too, and you know what it's for. It's for shock and to get people's blood pressure up. This is your own body trying to compensate for crazy. It's trying to get the blood pressure back up, and in between and around and down and upside down, this is going on. All this is going on. While all this is going on, your pulse also goes up. And I really need you to hear me on that. Let's do that again. Your blood pressure is low. It stimulates your baroreceptors to trigger the brain to kick into a fight or flight response, which is called the sympathetic nervous system. The sympathetic nervous system responds by putting out epinephrine and norepinephrine. Epinephrine gives you a very high pulse and blood pressure because it's vasoconstrictive. Norepi is more focused on the blood pressure because it's vasoconstricting. And so now you've got a high pulse or tachycardia, and you've got a bump in your blood pressure. This is going to be a problem. Let's explore what problem does tachycardia cause? Why am I trying to not have tachycardia when I have heart failure? Well, number one, when you have tachycardia, your heart rate's beating so fast, you are not giving the heart time to fill up with blood, which means you are not allowing for adequate, write it down, diastole. You are not allowing the heart to fill up with blood. You are not allowing this heart to have adequate diastole, because diastole means filling up with blood. And that is just not happening. So when that happens, you are reducing your cardiac output in terms of your volume, your stroke volume. The other problem with tachycardia just going crazy, like, when a patient has tachycardia, it uses up oxygen. So now you're using up oxygen that this heart definitely needs. So we need to give you a medication for that too. And you know what it is. It's where? B for beta blocker. It acts on the sympathetic nervous system or the stress response. An example of this beta blocker, the number one, I know you want to say metoprolol, but not for this. It's carvedilol is actually number one because you need an extend release type of medication. If metoprolol is given, it's going to need to be the one that says succinate. So metoprolol succinate, not tartrate. It's metoprolol succinate. So carvedilol is preferred. Metoprolol is okay. We are going to check the pulse because beta blockers and any other blocker can notoriously make the pulse low and cause a bradycardia, which is what you see here. We're going to teach what we always teach with blood pressure meds. Not only are we checking the pulse, we're checking the blood pressure, but it's the pulse that can go down really low. But here's what we teach with all blood pressure medications. Rise slowly and don't be in the shower, in a hot shower, for longer than 10 minutes, because what's a hot shower going to do? Vasodilate, you're going to get dizzy, and you're going to fall. I had a student that fell, and he was 6 foot tall, and he fell in the shower because of his beta blocker. He sure did. Now, don't forget your basics. This beta blocker is not the greatest for diabetics because it can mask hypoglycemia. What does that mean? It means that when you take a beta blocker, it blocks the stress response. So it blocks tachycardia. It blocks when you're stressed. What else happens when you're stressed? Sweating. It blocks that. It blocks you from, having palpitations or feeling your heart racing and getting all stressed out. It blocks that. And that's a good thing, because some of you guys need propranolol for test anxiety. That's another beta blocker for test anxiety. It blocks the stress response. The only problem with that is part of how a patient and us, part of how we know that you have low blood sugar is you sweat. Oh, and you shake. Well, it's not going to let you shake and sweat and be tachycardic. So I won't know, and nor will you, if your blood pressure is low. Is this making sense? So again, beta blockers mask, cover up, hide hypoglycemia. So it's not the best for diabetics. Also, it's not the best for significant lung disease because it can cause some bronchospasms. So COPD patients, serious asthma patients, it may not be the greatest drug, but I'm letting you know it definitely is a congestive heart failure medication. Okay? And here's the deal. Remember, because tachycardia stresses the heart, uses up oxygen, doesn't allow for diastole or filling of the heart, we really would prefer that this patient's heart rate hang around the 70s. Anything 70 and below is great. Sometimes it goes too low. We do not give metoprolol with a heart rate under 60. Okay. The next group of medications, not technically used a lot for CHF, but here might be the reason why they would use it for CHF. Calcium channel blockers may be used if the patient has some pre-existing dysrhythmias, like the patient already has been diagnosed with AFib and aflutter, or aflutter, right? Not and, but either one. Maybe they had a history of SVTs. Well, guess what? These drugs also are blockers and can cause bradycardia, so you have to watch it. And they're not routinely CHF medications, but don't be shocked if your patient's on them if they have pre-existing what? Cardiovascular disease in which they had AFib, aflutter, or something else going on. All right, now the big one, you know it's huge, digoxin. Now what's funny about digoxin is that it is a very popular medication on NCLEX, but it's not a popular medication with CHF. But it is traditionally considered in the past a CHF drug, so we got to cover it, and you know it's popular on any test. So let's look at it, because frankly, my mama was on this, and so, I had to know all about my dig, honey, because my mama was taking this. Here we go, digoxin. It is a inotropic drug that increases the strength of the contraction and decreases the heart rate. The problem with that is the reason why we don't like to use digoxin as much as we used to is because it can become toxic kind of quickly. Here's a way it can become toxic real quickly. If K, or potassium, if potassium is low, dig is high. That's true for magnesium as well. So potassium or magnesium is low, dig is high. That's going to be a problem. So there you go. If K is low, dig is high. What is high? Toxic is higher than 2. How would you know? What is the number one way to know that digoxin is toxic? I know you want to say green and yellow halos. I know you want to say visual disturbances. I know you want to say bradycardia, but no. The number one way, now all of that is true, by the way, but the number one way that dig is toxic is vomiting. And please remember that's number one, because the reason why green and yellow halos or visual disturbances is not the answer for the number one reason or the number one symptom for toxicity is because a lot of babies are on digoxin and they can't tell you green and yellow halos. They sure as hell can't tell you visual disturbances. So you feeling me on that? Okay, so that's it right there. Now look what I did. D and D. What's the second D? Oh, that's the lifesaver. That is the big deal. D for diuretics. D for what kind of diuretics? Because not all diuretics are created equal. However, I will say this patient could use any of them, but let's talk about what's going to save their life. Because like I said, 95% of these patients that you're going to meet are going to be in class C. And when they're in class C, they're hospitalized, and we need to help save their life because they can die. Remember, I told you that. So here we go. These are loop diuretics. They work on the loop of Henle to excrete sodium and water. All right, I hope you heard me. They work on the loop of Henle to, I'll say it a different way, to prevent the retention of sodium and water. The only problem is not only does it get rid of sodium, it gets rid of water and it gets rid of K. Now that might be a good thing because ACE inhibitors made you retain K. So you got a lot of reasons why your ass better be checking that potassium with these patients, because it could go high, it could go low, it could go all over the place, which is why all of these little areas say, you know, watch the K, right? Okay, you got to watch the K because DIG could become toxic. You got to watch the K because this loop diuretic is potassium wasting. You got to watch the K because this ACE inhibitor can cause potassium retention. I mean, woo, honey, watch the K. All right. Now, what is the deal with the test? Well, you know this test ain't gonna put no damn furosemide on there. They not finna give you Lasix. No, the hell they not. They gonna give you bumetanide or worse, torsemide. Look, bumetanide or torsemide are exactly the same thing, relatively speaking, as furosemide. Okay, now. They are loop diuretics that can be ototoxic. They are definitely potassium wasting. They are critical for the acute management. You're going to be giving this patient Lasix or bumetanide or torsemide IV push. But when you push that bad boy so you don't cause this damn patient to go deaf, you need to push that bad boy like every other IV medication you ever going to push over 2 to 8 minutes, 2 to 6 minutes. And LPNs cannot push anything IV. You know that. I'm just reminding you about your delegation. Okay, so IV push, here it is, IV push slowly. This will decrease preload because preload is all about the volume of fluid. If I give a loop diuretic, I'm going to get rid of the volume of fluid in the body. And that's going to help because those ankles look like shit. All right, moving on. Now, we did the categories. We did the A, B, C, and D, and we had 2 Ds. I hope you know we had 2 Ds. Now, we down here. Just because we down here and it says other critical meds don't mean that you can take these meds lightly. Oh, no. Matter of fact, a lot of the meds on my board right here are some of the new, more latest guidelines because we have something called guideline-directed medical therapy. Let me show you what I mean. G, write this down, G, D as in dog, M, and then we have a T. Guideline-directed medical therapy. You got to know that word because it's evidence-based medicine. So these medications down here, these CHF medications, congestive heart failure medications down here, some of this is very brand new for you. Although we've been doing it for a couple years, it's going to show up on the test and you're going to go, what the fuck is that? Okay, so stay with your girl. Because remember what I told you? I said the 75% of the medications on NCLEX are psych meds. The others are cardiac meds. Okay, now, so other critical meds. Spironolactone. Watch this. Spironolactone. It spares the K. Spironolactone spares the K. Therefore, it is a diuretic that is potassium sparing. Spironolactone, that's how you're going to remember it. Now, spironolactone will retain decay, so you still have to monitor the potassium and the creatinine. Like I said, kidney function, creatinine. Okay, all right. Isosorbide, please write this down. Isosorbide is a maintenance nitro. So isosorbide is a nitro drug that vasodilates and can be used on a maintenance basis, not just when you have chest pain. So this is isosorbide. It's a vasodilator. You know that nitro, as its #1 side effect, gives you a headache. So do ding-a-ling drugs because they vasodilate. Remember that? Viagra and all that gives you a headache. So, you know, vasodilation gives you a headache. How do we fix a headache? Vasoconstrict. What's the #1 thing that fixes a headache? Coffee. What's in coffee that vasoconstricts? Caffeine. Okay, you got to know this stuff. All right. Now, here we go, guys. So we went through these 2 drugs. Arnie is back. Arnie's ass. Please write this down. Arnie's ass is A-R-N-I. Arnie. Arnie, or A-R-N-I, stands for this: angiotensin receptor. This is a hard word. Neprilysin. N as in Nancy. E, P as in Paul. R as in Robert. I, L as in Larry. Y as in yoga. S as in Sam, I, and then N as in Nancy. Neprilysin inhibitor. Look up here. When a patient has CHF, their ventricles are stretched too big and they're working too hard, and to compensate for these ventricles that are being stretched, the ventricles put out something called B-type natriuretic peptide. As you know, it's a blood test that tells us you're having an exacerbation of CHF. Well, this B-type natriuretic peptide is put out by the ventricles when they're being stretched, and it's supposed to inhibit, you ready? It's supposed to inhibit angiotensin. BNP is a good thing. Well, Arnie is supposed to put out or help with B-type natriuretic peptide. It's a natriuretic drug. Please write that down. Arnie is a natriuretic drug. Now, here's our deal. Are you ready? The brand name, which I bet you've heard because it was on the commercials like crazy for the longest time, still is. The brand name is called Entresto. Remember, I told you when them television commercials come on, bring your ass wherever you are in that house and pull yourself in front of this TV and look at what that drug is and write it down because it's on the test. Entresto is a brand name. You know damn well this test ain't got no brand names. So what is the actual generic name? You ready? Sacubitril, okay? S-A-C-U-B, sacubitril, and then it's combined with an ARB. Watch this. Valsartan. Sacubitril with valsartan makes up the Arnie drug, which is actually going to enhance BNP. BNP. Oh, I know it's a lot, y'all. I'm almost done. Okay. Last drug category that you really gonna trip on. Years ago, a drug category called SGLT2 inhibitors came out to treat diabetics. The last part of those medication names, and this is going to help you on your test, the last ending, the ending of those drugs that they put out to help the diabetic was called Flozins. These Flozins, F-L-O-Z-I-N, these Flozin drugs were really interesting because what they would do with the diabetic is they would make them pee all their sugar out. So I used to teach you when I taught this drug, you're going to be flowing with that urine. Your sugar about to be flowing on out with the urine. And then the patient, though, would get like, look, genital urinary fungal infections, yeast infections, UTIs with yeast in it. And that's still true for some people. However, this SGLP, sodium glucose co-transporter 2 inhibitor, is now considered the miracle drug group for CHF. Like, I'm serious. It didn't really take off as a diabetic drug. It became a cardiac drug, and it helps this patient's ejection fraction, and it's even better than that. OMG. This group of drugs decreases the death rate and the hospitalizations of this patient. My God. So now it is required. It is evidence-based medicine. You can't take a test and not know this. This is brand new. Now, I know the doctors don't always teach this, but you're a freaking nurse, so get it together. We have found for stage A and B that if this patient were to exercise, lose the weight, control their sodium intake, it would be just almost as good as drugs, but not quite, because you still need the medication. So that's why it's not as good. But damn, it would be very effective for stopping the progression of CHF. Here we go again, okay? Exercise, low sodium diet, which is also called DASH, dietary alterations to stop hypertension, weight loss. And remember I said for weight loss, those GLP drugs are the shit. Okay, that's that weight loss medication. That shit works. Okay, we don't do as much fluid restriction. Put a note here, put a big old star. We don't do as much fluid restriction. We consider this a very PRN. You really, really sick. I might have to do it, but we don't do it as much as we used to. You might want to note that. So I put PRN, fluid restriction PRN. But then you know what I'm going to say? Daily weights, boo. Yeah, daily weights. Now, daily weights, you know that's going to be the first sign of fluid retention, not edema. In fact, you've got to gain about 10 pounds before you see edema. So remember it like this. 2.2 pounds equals a whole liter of fluid on the body. We tell our patients to call us when they gain 3 pounds in a day or 5 pounds in a week. You knew that. This is not your first rodeo. And they need to weigh themselves with the same scale, same time every morning after they pee, but before they eat, naked preferably. Okay? Now, I want to say one last thing before I go. This ARNI medication, notice it has a sartan drug or an ARB right in it. Therefore, when we start the patient on an ARNI medication, they must be off their ACE inhibitors or their ARBs for 36 hours before we can do that. I know it was a lot, damn near an hour, but listen, this is heavy duty stuff. I told you I'm going to be doing a lot of the cardio videos over because management is just, you know, for a lot of this stuff, it changes. And you looking at something called heart attack and they talking about Mona. We don't do Mona no more, baby. Just like for CHF, we got 2 new drug categories. It's not just an ACE inhibitor. In fact, ARNI should replace the ACEs and the ARBs over time. I hope you got something out of that. If you didn't, I'm going to say it again. If you all up in my boot camp, because you know at boot camp, we do medications. We do everything at boot camp. Procedures, basic care and comfort, reduction of risk. So if you're going to come up in my house and come see me on January 17th, 18th, and 19th, or we added February date, February 28th, March 1st, or 2nd, then I will have lots more of this for you then. Now, you want anything or need anything, you text me, 216-410-0936. I'm more than happy to do what I can to help you get through this very challenging career education process. Deuces.